Good evening, friends. Welcome to Tuesday's masterclass webinar from Yashoda Hospitals in association with Hyderabad IDCCM from the Department of Critical Care Medicine. So basically, we bring out regular sessions which are examination topics which are useful for all the students. So regularly, we will be reviewing these topics along with senior seasoned clinicians and examiners of all the exams. So for today's topic, I welcome Dedeepiya sir. Hello. Yeah, Dr. Dedeepiya Devaprasad. He is a senior consultant critical care medicine from Apollo Hospitals, Chennai. So today's topic for discussion is pulmonary thromboembolism. For this, we have Dr. Syed, Ahrar Raja and Dr. Mallikarjun Kurni. Both are DrNB final year students. So they will be presenting the pulmonary thromboembolism today of their case. So, Dr. Mallikarjun, you can start. It will be 1 minute. Yeah, 1 minute. Just wait for Dedeepiya sir. He is going to join. Dedeepiya sir, good evening.
Yeah, I can hear you.
Yeah, Dedeepiya sir,
Hello?
good evening.
Can you hear me?
Yeah, yes. We can hear you, sir.
When we go, let me know. Okay. Lot of rains here.
Yeah, welcome on board, sir.
Okay, sure.
We're very happy to have you on our platform. So, shall we start, sir? Yeah, just give an introduction. So we'll go ahead. Dr. Mallikarjun is going to present the case, sir.
Sure.
Yeah, Dr. Mallikarjun, you can proceed.
Yeah, good evening, sir. Today my topic of discussion will be on pulmonary thromboembolism. Sir, is the screen visible, sir?
Yeah, it's visible, Mallikarjun. Venkat sir also joined.
Introduction. A 69-year-old male with the comorbidities of diabetes type 2 since 15 years, who is on oral hypoglycemic agents, hypertensive since 15 years on telmisartan, and chronic kidney disease with a baseline creatinine of 1.8 milligrams per deciliter, and is also known as bronchial asthma patient, but not on any therapy. He presented with complaints of left calf pain for 3 days, and he went to the local physician and was advised NSAIDs. The night prior, he developed sudden onset of shortness of breath, grade 4 MMRC with sweating and cold extremities. So with these complaints, he went to the local hospital and was found to have non-recordable BP, mixed acidosis in arterial blood gases. He was resuscitated with fluids there. He was initiated on NIV, non-invasive ventilation, and was referred to our hospital for further management. So in the ER, his vitals were blood pressure of 100 by 60 mmHg on left arm with borderline blood pressure, heart rate of 100 per minute with tachycardia, temperature normal, respiratory rate slightly tachypneic with use of accessory muscles, and SpO saturation of 100% with NIV on FiO2 of 60%. His Glasgow coma scale was E4, V5, M6. Our ABG showed mixed resources with type 2 respiratory failure and high anemia metabolic acidosis. And his ECG was suggestive of right ventricular strain, that is S1Q3T3 pattern. So quick general examination, patient was conscious, coherent, restless, and dyspneic. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Respiratory system examination showed bilateral equal chest rise with use of accessory muscles. On auscultation, bilateral air entry was present. There was slight decrease in the posterior basal region. Point of care ultrasound showed lung sliding was present with bilateral A profiling. Cardiovascular system, auscultation, S1, S2 were heard. No murmur heard, and screening 2D echo, that is showed dilated right atrium, right ventricle with right ventricular dysfunction in terms of TAPSE of 12, that is tricuspid annular plane systolic exertion, with the D-shaped LV, left ventricle, and distended IVC. Per abdomen, soft, non-tender, no organomegaly, bowel sounds present. CNS showed higher mental functions normal, no focal neurological deficit. And DVT screening showed 4-point compression negative at the bedside. So in the year he was intubated because of his hemodynamic status and also
Dr. Mallikarjun.
Sir.
Yeah, I think go back to the second slide. Yeah. So yeah. So basically, with this background, when the patient came to ER, what are the concerns for you?
So he's the elderly. He had calf swelling and is a known CKD patient. So my concerns are he could be in sepsis with septic shock, and the sudden onset of severe shortness of breath along with tachycardia will make me this pulmonary embolism as a likely diagnosis in my differential, sir. So it could be septic shock and obstruction, sir.
1 minute, yeah.
Okay, can you go back to your first slide on the history? Yeah, the first slide. So, okay. So with this history, at this point of history.
Dedeepiya sir, your voice is breaking in between. Yeah.
Hello?
Sir,
yeah.
Yes, sir.
Am I audible?
Yeah. Sometimes it's breaking, sir.
So your network is poor, sir. Please check your internet connection once.
Hello.
Yeah. Now you are audible, sir.
Hello.
Dedeepiya sir. Yeah.
Kaladhar sir, there is some network connectivity issue. It's a
Okay, sir, may connect again.
Yeah.
So basically, Mallikarjun and Ahrar. So with this background, so 69 elderly, as you said, diabetic hypertension, and basically he did not have any history of fever. No? As such, he did not have any history of fever.
No, sir. No history of fever.
Only the history is left cough pain, and he received NSAIDs outside. Next slide, I think.
Yes, sir.
So what about is regarding bronchial asthma? Did you ask about the history of past history of any issues regarding bronchial, how it was controlled, well controlled, any history of recurrent exacerbations?
It was long back, sir. Diagnosed long back, almost 20 years back. But he took inhalers for less than 6 months, and then he stopped. And he didn't have any exacerbations then.
Okay. So he did not have any exacerbation. Otherwise, baseline any nebulizations. At home, any thing he was using. Only history of bronchial asthma is there, but otherwise it looks to be well controlled.
Yes, sir.
So, basically, initial differentials anyway, you said the concerns, first of all, patient basically having a shock and there is hypoxia. What are the concerns? How do you proceed to this type of patient when you go to ER and you are assessing the patient? What are the concerns first and foremost? How do you stabilize the patient?
So airway, breathing, circulation, sir. First things.
Okay.
And I would look for type of respiratory failure, sir. So if it is type 1, type 2, I'll see which type of respiratory failure is having, sir.
Okay.
Respiratory failure based on the differential, I will look out, sir. So if it is type 1 respiratory
So
failure,
this patient is having what type of respiratory failure?
He was having type 2 respiratory failure, sir.
So, on the background of history of bronchial asthma and the patient is having type 2 respiratory failure, what is the foremost important consideration for you?
So it could be because of exhaustion, sir, use of his muscles, accessory muscles, and it could be because of exhaustion. Initially, bronchial asthma patients would hyperventilate and they would wash out the CO2. As there is exhaustion and respiratory fatigue, they would go into type 2 respiratory failure. At this point, he more or less would be having silent chest, a decrease in air entry. But this was not the cause here, not the picture here. He was having bilateral air entry and chest rise was normal. There was only a slight decrease in air entry in the posterior basal zone.
So compare and contrast type 2 respiratory failure in bronchial asthma versus COPD. Which is more concern?
Bronchial asthma, type 2 respiratory failure is more concerned, sir. That is impending respiratory failure, and we have to intubate the patient to secure his air.
So basically, whatever you said, these bronchial asthma patients, if they present with acute exacerbation and bronchospasm, so those patients tend to hyperventilate and PCO2 tend to be on the lesser side, 25 to 30 like that. But when patient is PCO2 is normalizing, not even hypercapnia, only normalizing. That means near to 40 itself is a very concerning thing in the patients of bronchial asthma. So, what do you think about the labeling bronchial asthma, this patient of a 69-year-old? Do you think the diagnosis is appropriate or anything is missing?
So bronchial asthma, I would have in the back of my mind, but the patient had a long history of bronchial asthma, and he was not on any nebulizations or anything, and he was maintaining well. So the sudden onset of shortness of breath with a background of lower limb swelling and known diabetic.
Basically, in the elderly age, labeling bronchial asthma is a bit unusual.
Elderly
Patients, elderly, most of the times it points towards possible COPD or generally asthma COPD overlap syndrome, ACOS. Those are the possibilities rather than pure bronchial asthma, as it is most common probably in the younger group and then continues in the life. Rather than elderly diagnosing first time as bronchial asthma is a bit misinterpreted diagnosis most of the times. So possibly he might be having COPD. Any history of smoking in the past?
No, sir. He was alcoholic. He had substance abuse, alcoholism, but no smoking, sir.
Okay. So, yeah, I think, bronchial asthma as such is you are not considering, and in your subset, this patient, index patient, basically, there was a type 2 respiratory failure, but as such, you did not find any bronchospasm because the lungs were looking clear.
Yes,
so
sir. No phase.
Yeah. So, other than bronchospasm, some other thing is contributing to is hypercapnia, possibly. That's what your intention. So,
Yes.
when you are taking, I think Dedeepiya has joined. When you are intubating this such type of patients, as you said, airway, breathing, circulation has to be taken care, and both all things have to be simultaneously. So, what are the things that you organize yourself in the ER? How do you instruct your nurses, other helping doctor, and all? How do you instruct and how do you organize yourself, securing airway and maintaining circulation and all? Can you tell it?
Sir, I would first of all, I would like to keep the airway, difficult airway tract reducer. So I haven't assessed the patient's airway first. So I'll assess quickly. I'll assess the airway of the patient using basic 11 score. So I'll see, and then I'll keep all the emergency drugs, including those required for the cardiac arrest, ready with me, sir. So, and also regularly I'll be using 2 laryngoscopes, bougie, and other airway, intubation devices. And then I'll do, hemodynamic, for hemodynamic instability, I'll start with the 2 large IV port cannulas, and I will start with the drip. And I'll see to it that, in the event of respiratory or cardiovascular collapse, the team is ready for that, sir.
Okay.
Hello.
Yeah, Dedeepiya sir. Yeah, we are able to hear you, sir.
Yeah. Okay. You just told us the difference of why you think it is not acute exacerbation of asthma with type 2 respiratory failure. Other than that, what was your differentials at this point of time? You said you didn't think that was the case. Your differentials were?
Sepsis, sir. Sepsis with septic shock.
Sepsis.
And
you said sepsis with septic shock, given that he's CKD and got a swelling. So you thought in terms of a skin and soft tissue infection, right? That's what you thought.
Yes, sir.
Okay. Anything else?
A pulmonary embolism, sir. So unilateral
pulmonary embolism. What do you think were the risk factors of pulmonary embolism for him, given this history at this point of time?
Age is 50 plus, sir. So unilateral leg swelling is present.
Okay.
He is a known diabetic, though it is a very low risk factor, but diabetes, he has a comorbidities of diabetes and hypertension. And given the clinical...
I understand that he has probably pulmonary embolism because we know the cases, but at this point of time in the history, what do you think are the risk factors for pulmonary embolism that he has?
That's what lower limb swelling, unilateral lower limb swelling, age, and the sudden onset of shortness of breath with tachycardia. All these clinical signs and symptoms were like making the differential of this. Pulmonary embolism. Sir.
Okay.
And
Was there any immobilization before it?
There was no immobilization. Sir. There was no immobilization. There
Okay.
was no history of travel. There was no
Okay. No history of
hospitalization.
recent travel. Okay. No
Yes.
history of immobilization. History of any cancer?
No cancer, sir.
No cancer. Because in this age group, other than that, nothing major, no? That
Yes.
can cause. Okay, fine. So your other differential was pulmonary embolism. What was any other differential that you had?
Sepsis, pulmonary embolism.
You said
and,
sepsis. Sepsis. You said with sequence of tissue infection, acute pulmonary embolism from cough in DVT. Sorry.
Myocardial infarction. Sir.
Myocardial infarction. Okay, myocardial infarction. Okay, okay then. Please. The next slide in the ER. In the ER, next slide that you showed in the ER slide. Okay, in this vitals, what were your concerns here?
So he was having heart rate of 100 per minute. It was tachycardia. So blood pressure was in the borderline, sir, 100 by 60. So he was a known hypertensive, so it could be like hypertension, because if it is more than 20% of his previous blood pressure, so it could be hypertension. And the respiratory was 24 per minute. He was slightly tachypneic, but his accessory muscles, he was using accessory muscles for breathing, sir. So
okay, since you said you had sepsis in your mind, with these vitals, any parameter that you would want to say in terms of sepsis that will determine you?
Blood pressure
that you
and heart.
Normally. Sorry?
Blood pressure and heart rate.
Sorry?
Sir. Blood pressure.
And heart rate. And any parameter, the clinical parameter that you will check in patients with sepsis and risk stratify them?
Lactates.
Lactates, okay.
ABG lactates were slightly elevated. So 3, they were elevated.
Any composite of 2 or more organ involvement that you can use and say risk stratify that you will do in sepsis in the ER or in the ward to determine where they should go? I'm just asking you, what is the Q so far? I know it's not relevant to this particular case, but since sepsis was also your differential, I just wanted to know what the Q so far.
The respiratory rate of more than 22, systolic blood pressure of more than 100.
Okay. And
heart rate.
What are the components of Q so far? 2. One is respiratory rate that you said. One is blood pressure. The third is
heart rate.
Altered mental status.
Altered mental status. Sorry, altered mental status.
Altered mental status. So any 2 upon 3 will tell you that this is Q so far positivity. So I'm just saying, if this was sepsis, do you think the Q so far was significant?
Yes, sir. Respiratory is more than 22, and systolic blood pressure is, like borderline 100, sir.
Blood pressure is 100, no? More than 100. So maybe 1 upon 3 only at this point of time. Okay, fine. Okay, saturation was 100% on NIV, 60%. You talked about the ABG. So what do you think was there in the ABG?
Type 2 respiratory failure and high anionic gap metabolic acidosis was there, sir.
So what is the cause of high anionic gap metabolic acidosis in him?
Could be diabetic ketoacidosis, sir. His ketones were borderline elevated, and sugars were also uncontrolled. And he had a component of CKD, sir, chronic kidney disease. But CKD usually possesses nagmas.
So you said that it could be uremia, which can cause high anionic metabolic acidosis. Since he's a diabetic, it can also be a DK, which is causing high anionic metabolic acidosis. So did you look for the and obviously because he's in shock, lactates itself, elevated lactates, can they isolatedly cause high anionic metabolic acidosis?
Yes, sir.
Okay. So do you think did you check for urine ketones or serum ketones?
Serum ketones initially were elevated, 1.3 something, sir. So when he came to our hospital, it was like 0.3, 0.6, I think so.
Okay. So you did talk about S1Q3T3. What is the value of this?
S1 Q3 T3 signifies RV strain pattern, sir. So it is a little specific, but not sensitive to pulmonary embolism, sir. So if it is negative, we cannot rule out pulmonary embolism. But if it is positive, the specificity itself is also very less.
Okay. So what, as you said, it indicates RV strain. So what are the conditions other than pulmonary embolism in which you couldn't see the S1 Q3 T3?
Any cause of right ventricular strain like pulmonary stenosis,
Okay.
pulmonary embolism, any chronic, respiratory disease.
Okay. So you did talk about COPD. Can COPD also cause S1 QT3T? COPD with pulmonary hypertension can, no?
Pulmonary
In heart,
hypertension, yes,
right heart failure. Yes.
right, yes.
Okay. Okay. Can patients with you said sepsis? Suppose he goes into sepsis and severe ARDS. Can he have S1 QT3T?
Severe sepsis with ARDS. I mean, if the patient
with severe
has
ARDS.
severe ARDS.
Severe ARDS and they go in for pulmonary hypertension acute.
Yes, sir.
Yes, you've seen. So, very nice. Just to let you understand that S1 QT3T is not very specific for pulmonary embolism. You said that. Just asking you the other causes of S1 QT3T. While we're staying on the ECG, can you tell me what is the commonest ECG findings of pulmonary embolism?
Sinus tachycardia will be the commonest reason.
Sinus tachycardia. Okay. So sinus tachycardia. So if you say sinus bradycardia in a patient with pulmonary embolism, what does it tell you? Can you see it at all?
It can be seen, sir. So in case of massive pulmonary embolism with hemodynamic compromise, sinus bradycardia may be seen.
Can be seen. So what does it signify?
Massive, the severity of pulmonary embolism causing hemodynamic compromise.
It signifies that this patient is going to have an impending cardiac arrest.
Yes, sir.
Just as how you see bradycardia in a hypoxemic patient, you know it's an impending respiratory arrest. Likewise, in a patient with pulmonary embolism, if you have severe bradycardia or bradycardia, anything less than 50 in them is impending cardiac arrest at this point of time in them. Okay then. Okay, please continue. Your next slide, please.
Regarding one question, Mallikarjun, regarding ABG,
so
what do you think? What are the findings that you see if it is a pulmonary embolism in ABG?
In pulmonary embolism, usually we see because the patient will be hyperventilation. Usually we see decreased PCO2, pH will be in the normal range, and PO2 will be low. So
that's right. Yeah. So basically, the patient will be having mostly hypocapnia. The hypercapnia is not very common, but if it is a massive pulmonary embolism, possibility of hypercapnia will also be there.
Yes.
Because of the more and more shunt. Yeah.
So quick general examination. Patient was conscious, coherent, restless, dyspneic, no pallor icterus, cyanosis, clubbing, lymphadenopathy, or edema. Respiratory system has shown inspection of bilateral equal chest rise with use of accessory muscles, auscultation, bilateral air entry present, no additional sounds, decreased air entry in the posterior basal region. Point of care ultrasound lung has shown lung sliding present with bilateral A profiling. Cardiovascular system on auscultation, S1, S2 heard, no murmur heard. Screening 2D echo at the bedside. Transthoracic echo has shown dilated RA-RV, right atrium and right ventricle with right ventricular dysfunction in the form of TAPC of 12 with the D-shaped LV and distended IVC. Per abdomen, soft, non-tender, no organomegaly, bowel sounds present. CNS, central nervous system, higher mental functions are normal, no focal neurological deficits. DVT screening at bedside chore, 4-point compression test is negative. So, in view of his impending respiratory arrest and
at this point, sorry to interrupt. At this point, that you finished your history or clinical examination, what is your diagnosis at this point?
It is looking like pulmonary embolism, sir, because the 2D echo is showing dilated RARV with the D-shaped LV, and he's having, hemodynamic compromise, so severe pulmonary embolism.
Pulmonary embolism. Do you want to just use some more adjectives to describe this pulmonary embolism?
Severe.
Massive pulmonary embolism.
Massive pulmonary embolism.
Okay. Do you want to call it? When do you call it massive pulmonary embolism?
So if there is hemodynamic compromise, we call it as massive. No hemodynamic compromise with the RV dysfunction present in the 2D echo and clinical signs of pulmonary embolism present, we call it as submassive. And also, there is a saddle embolus at the junction of this thing, then we call it as massive pulmonary embolism.
Okay.
But ideally,
So
massive pulmonary embolism.
Okay. So in this particular patient, was there hemodynamic compromise or not?
Yes, sir. His BP was 100/60. He had cold extremities. So we have started him on dual vasopressor support.
So because he was hemodynamically unstable. So you're just saying that if the patient has got hemodynamic instability, you want to classify this as massive pulmonary embolism. And you did also clarify about what is called submassive pulmonary embolism. Can you tell us what is submassive pulmonary embolism? When do you call it? You did tell us, but can you just...
Submassive pulmonary embolism, there should be no hemodynamic instability and RA, there should be clinical signs of pulmonary embolism with RA dysfunction in the 2D echo, sir.
Okay. So anything can show RV dysfunction. So can we just say that massive pulmonary embolism, you have three factors. Patient should have hemodynamic instability, or they should be pulseless. Patient with pulseless, and you think there's a pulmonary embolism. That's also massive pulmonary embolism, right? Arrest. PE arrest. Yes. Pulmonary embolism with arrest, PE arrest. That is massive pulmonary embolism.
PE cardiac.
Pulmonary embolism with massive hemodynamic instability is pulmonary embolism. And as I told you, patient having severe bradycardia, impending arrest, that is also massive pulmonary embolism. So these are the three situations where you call it massive pulmonary embolism. So anything other than that, where you don't have hemodynamic instability and you have an evidence of RV dysfunction, either as you say, as in echo, or in the absence of echo finding, if you have chemical evidence of RV dysfunction, like what yes. could be the chemical
troponins and
evidence?
DNB. Troponins
yeah.
and
so they either have raised troponins or they have a raised BNP. There again, it could be classified as submassive pulmonary embolism. Do you think this classification is actually important or not?
Yes, sir. The treatment would differ. The way we approach the patient would be different, sir. So,
okay. So we'll leave it that because you've not come to the treatment. So we'll catch up when you come with treatment. I just wanted at this point of time that making this particular distinction is important. Probably we'll come back to that when you talk about your treatment, not interrupt. Can you just continue, please?
Sir. So patient was intubated in the ER, lines were secured, and it was initiated on dual vasopressor support. Routine blood investigations like complete blood picture, renal profile, and liver function test was sent, along with D-dimers. Blood and urine cultures also were sent, and empirical antibiotics initiated. So this is his
okay, sorry. Can you stay on the previous slide, please? Previous slide. Intubated. Okay. Since your diagnosis was massive pulmonary embolism prior to intubation, okay, you intubate. What was the reason for intubation?
So he was having accessory muscle use, and his ABG was showing metabolic acidosis. 6.9 was his initial ABG, and after resuscitation with 7.01 was his ABG. Sir. So we have intubated in view of metabolic acidosis requiring hemodynamic support and impending respiratory failure. So
three reasons you intubated him because of severe acidosis that could be life-threatening, severe life-threatening acidosis, type 2 respiratory failure that is leading to an impending arrest, and obviously severe hemodynamic instability. Those are the reasons for intubation. Considering that's perfectly fine. Considering that this particular patient has a background of severe pulmonary embolism with hemodynamic compromise, what are the problems you anticipate while intubating these patients?
I mean, sudden cardiac arrest is a problem, sir.
Okay. Why do you think it can happen?
Because hemodynamics or borderline, once we give anesthetics and any analgesics, so there could be like, precipitous fall in BP and cardiac arrest.
Okay. Any precaution that you will take while intubating these patients?
Volume status,
Okay. What will happen if you give a lot of volume to these patients?
I mean, the right ventricle one takes the load, sir. So if there is like severe load on the right ventricle and on top of it pulmonary embolism, the patient right ventricle might
Okay. And you
like
already
collapse.
said,
So
and already you said it's a deep shade ventricle compressing the LV cavity. So what would happen?
if it is like dilated ventricle and not able to push, then the cardiac output will also decrease, sir, because of the interdependence of the ventricles.
So if you're going to dilate the RV more indiscriminately, then you could cause more LVOT obstruction. Is that right?
Yes, sir. Yes, sir.
Okay. So judicious use of fluids and appropriate use of vasopressors may be essential in this particular patient. And remember, even when you're bagging this particular patient, when you're causing a lot of bagging, that also has its own effect on the LVOT. So these are concerns that you have. Any other precaution that you will take when you're intubating patients with this pH of 6.9? Are you concerned about his? How do people with 6.9 pH and all they breathe? No, they breathe. How do you see these people breathing? They're breathing very, very fast, is it not?
Very fast, sir. Yes.
Yes. His respiratory rate
24, sir. His respiratory was 24.
do you expect that it to be 24?
No, sir. Actually, we expect a lot of tachypnea and also
So
hyperpnea.
that itself is showing that he's probably fatiguing, is it not? Right? It's not expected.
Yes.
Probably in the outside hospital or wherever he went and came to you, there from there itself he's okay. So I'm just asking you, when you're intubating these patients with 6.9 pH, with impending respiratory failure, with severe hemodynamic compromise, with mixed metabolic acidosis, when intubating these particular patients, anything that you expect? Do you expect them to have an arrest on you when you're intubating
Yes,
these patients?
cardiac arrest.
If so, forget that he's got pulmonary embolism. I'm just forget for a moment that he's got pulmonary. We also said that in pulmonary embolism, what will happen if you're going to give too much of fluids while you're intubating these patients? We did discuss that. I'm just talking about the acidosis bit of it. Just say that we have intubated him for the severe DKA and you intubated him in this particular patients. Have you seen adverse outcomes peri-intubation in these patients? And how do you think you can overcome these outcomes?
Severe metabolic itself will act on the is a myocardial depressant, sir. So
okay.
the
So do you,
enzymes.
what are the agents? What are the agents you've used to intubate this patient?
In ER, it was rocuronium was used, sir. Rocuronium and fentanyl with midas was used.
Okay. So remember, you're using rocuronium. Okay. What effect will rocuronium cause on this particular patient after intubation? Okay. What I'm just trying to tell you is that suppose this patient was breathing at 40, which is usually the case. So after you are intubating these particular patients, you are bagging them at a more physiological rate, right? 15
Yes.
to 80, maybe 20 or something like that. At that point of time, you could expect severe acidosis because this particular patient was breathing at 40 and you are now controlling his breath at 20, right? So you could have severe acidosis. So be prepared. So in this particular patient, if they arrest around this point of time, it may be a wise thing to use judicious use of bicarb in these situations. It's been documented that in these situations with severe acidosis that you are intubating and especially controlling the rate with paralysis, you could expect a transient worsening of this acidosis more because of an additional respiratory component that you have induced by the use of a paralytic and controlling his respiration. So just be careful of it. Obviously, you have taken care of the sedative-induced drop in blood pressure by using up inotropes at this particular patient. I mean, vasopressors. Okay, that's perfectly fine. So you've done blood cultures and you said empirical antibiotics. I'm just curious to know what antibiotic was given to this patient.
It started with meropenem and clindamycin.
Meropenem. What was the rationale for this meropenem and clindamycin?
Meropenem was suspected like gram-negative sepsis, sir, and in our, I mean, like he had prior visit to the hospital where he was intubated. I mean, where he was treated for like 8 hours or so, and for clindamycin, he had this calf swelling, leg swelling. So for skin and soft tissue infection, we have put the clindamycin.
Okay, so the organisms that you're trying to cover were probably you're talking about a mixed infection with gram negatives, which you want to cover like E. coli, Klebsiella, Pseudomonas, and then you probably also want to cover gram positives, and maybe you're covering for MSSA with meropenem, and maybe for toxin production with dalacin, with clindamycin. Probably that's what. Okay,
Yes.
okay, please
Yes.
proceed.
So general examination ear vitals.
Yeah.
This
Yeah,
was
go
his ECG, and it was showing the classic S1Q3 T3 pattern. So he was immediately shifted to ICU and on waiting his results. I mean initial labs. On day 1 of ICU, he was immediately treated with the IV tenecteplase 40 mg. I mean systemic thrombolysis was given. After which we had this D dimers which were elevated around 5,000. TLC count also was elevated around 20,000 with procal of 15.4. So the patient was initiated on CRRT in view of oliguric AKM CKD and persistent high anionic gap metabolic acidosis and hemodynamic instability. So day 1 continued. Post thrombolysis, repeat 2D echo showed persistent RA-RV dilatation with right ventricular dysfunction. So an interventional radiologist opinion was taken at this point. So he advised for pulmonary angiogram, and he was taken on table. The pulmonary angiogram showed filling defects in the left pulmonary segmental branches and middle lobe of the pulmonary artery. So the pulmonary thrombus was macerated with 15 mg tenecteplase infused into the thrombus. So post procedure, patient hemodynamics improved immediately. So the next day, CRRT was continued.
Yeah, Mallikarjun, one minute.
Sir.
Ahrar, I think Ahrar is also there, na?
Yes, sir.
Ahrar, basically, how do you like test like probability that these patients are going to have pulmonary thrombus? I think this is straightforward. Whatever Mallikarjun is presenting looks like pulmonary embolism signs. Suppose generally, which patients are very high risk and which patients low risk? How do you stratify?
We differentiate between the patient based on the first is hemodynamics. If suspecting PTE with hemodynamic instability, it is considered as high risk. If patient is hemodynamically stable and is suspecting PTE, we will try to use the different criteria like Wells score and Geneva score. Based on that, we try to separate low risk, high risk, or P likely or unlikely.
Okay.
So, patient is in the low or intermediate risk, we can do a D-dimer test. Okay, if there are no other confounding factors for D-dimers, and if D-dimers are on higher side, we can do a CTPA to confirm the PT.
Okay. Can you tell the Wells criteria a little bit, like what are the variables that generally?
Yeah, absence of previous any first of all, can history of any immobilization for 3 days or surgery can last for 3 months, and then we have got any history of cancer, any previous DVT history or active DVT, then we any hemoptysis. Then we have this previous history of any PTE. And then we have this.
Yeah. Okay. What is the role of D-dimer?
D-dimer as such, in the low and intermediate risk, it has got a role wherein if it is increased and no other confounding factors, it can indicate the PTE. But in high risk patients, there is no role of D-dimer. Okay. Because even normal D-dimer in a high risk patient, a patient still can have PTE. Whereas in low and intermediate risk, normal D-dimer, probably you may rule out PTE.
So, what is the what is PERC score? Any idea about PERC score?
Yeah, pulmonary embolism rule out criteria.
Okay.
Actually, in the very low risk, we use that, sir.
Mm-hmm.
So if it is positive, then we can go ahead with further testing like D-dimer. Okay. If it is negative, then we can confidently rule out PT in low risk patients.
Suppose this patient is being hospitalized. After some time, he had shortness of breath. Do you consider sending D-dimer in this patient?
No, sir. In hospitalized patients, D-dimers, especially in ICU, there are many confounding factors in which the D-dimer
So
can
what are the
be
confounding factors that that can raise
patient,
D-dimer positive?
in hospitalized patient sepsis, it could be any whatever immobilization is this essential cause. It can be any bleeding, any clot anywhere, any procedure which has been done previously, or any surgery in the hospital stay can increase the D-dimer. DIC can increase the D-dimer.
So, Mallikarjun, yeah, what are the chest X-ray findings? Any chest X-ray, which are not very specific, but sometimes if you see, those are the chest X-ray signs that can point towards the possibility that patient can be having a pulmonary thrombolism. Any chest X-ray signs that you know?
In our patient, no chest X-ray sensor, but as such, a pulmonary embolism patient chest X-ray can have signs of infarction like Hampton-Sum, Westermarck sign, Pallas sign.
Mm-hmm. What is Hampton-Sum?
Hampton-Sum is the wedge-shaped opacity.
Wedge-shaped opacity indicating infarct.
Infarct, yeah. Westermarck sign?
Focal origemia, which present indicate Westermarck sign, and Freshness sign is enlarged pulmonary artery.
Perihilar pulmonary artery dilatation can be Freshness sign. Freshness sign.
So, what are the 2D findings that you specifically look at, like this patient is having pulmonary thromboembolism or not?
Right ventricular signs. So right ventricle McConnell sign is 1. 60-60 sign is 1. Tricuspid.
What is McConnell?
McConnell sign is right ventricular free wall dilatation with the apex being normal. So the free wall will be dilated and the apex will be glued to the septum. This is seen, it is not very specific for pulmonary embolisms. So mid part of the right ventricle will be dilated.
Considering will be there.
With apex being normal. Apex
Yeah.
is, but mid part of the right ventricle is dilated.
Dedeepiya, sir?
Okay. So you said you have treated this patient with. So we'll come back. You said the treatment will differ from massive pulmonary embolism and submassive. So this was a massive. So please tell us what is the usual treatment for massive pulmonary embolism. You've thrombolized this particular patient, obviously. So chemical thrombolysis. And what is the choice of agent? You've used tenecteplase, right? And why did you choose tenecteplase and why did you choose 40 milligram?
Tenecteplase, according to the weight, we choose less than 60, 60 to 70, 70 to 80, 80 to 90, and more than 90. So anything
Okay.
more than 90, 50 mg we use, sir. So 60, 70 to 80, we use 40 mg, sir. This patient weight was around 72 kilos. So tenecteplase
72.
40 mg was used, and it is 510 specific, and it has longer duration of action. That's the reason why
Okay.
we use
So,
tenecteplase.
any other agent that you can use, or have you used, and that has been studied?
Altiplase has been-
Altiplase is used, but I haven't never used altiplase. Only tenecteplase I've used.
Okay. So compare and contrast between altiplase and tenecteplase in terms of efficacy. Is there any difference at all?
No difference in efficacy, sir. No, I mean,
Why do you choose? How do you make the choice? Maybe just your comfort or anything else? Ease of use, no? Tenecteplase, just give it as a bolus, and altiplase for
Altiplase-
pulmonary embolism.
Altiplase need to be infused in a 1 hour period, sir. But tenecteplase we can give it as a bolus, sir.
Okay. Is there any particular situation in which you'll give altiplase as a bolus at all? Okay, fine. Let's come back to this patient. Tenecteplase. Suppose I say that you're given tenecteplase, and while you're giving tenecteplase, the bolus, after you've given it, the patient has a cardiac arrest. What will you do?
When the patient is having cardiac, I immediately follow the ATLS guidelines, sir. Start CPR.
Okay, start CPR. Okay, so the patient is already intubated. So, your A is, of course, it's now CAB. So you're going to do CPR. You're going to airways taken care of, breathing you're taken care of because you've already intubated this patient prior. So every 3 minutes you will give adrenaline, right? And every 3 to 5 minutes you give adrenaline and then check for your CPR, right? Give chest compressions. So how long
Yes, sir.
would you continue your CPR normally in your unit?
Normally, PT
Normally,
patients have to continue for longer times, around 60 to 90 minutes.
Okay. So normally, how much time do you
20,
continue
20
CPR?
minutes, 20 to 20 minutes, 20 to 30.
Specific, but generally, we all take 20 to 30 minutes of resuscitative time. And so there are specific guidelines for patients with pulmonary embolism, especially whom you have thrombolized. And rightly, as you said, you will have to give a longer duration of CPR. Have you personally seen patients who have recovered after longer duration of CPR?
Personally, no, sir. No patient.
Yeah. Okay. So we've have instances where we've resuscitated patients for longer durations, more than 60 minutes, and have had good neurological outcomes. So the point that we wanted to make out is that don't stop your CPR, especially with pulmonary embolism, especially when you've given the bolus of the drug. Have you suppose this is a different situation? So you've given the bolus and the patient arrests, you're doing the CPR. But let's say that while you're deciding that the patient has got pulmonary embolism, and even before you're deciding to thrombolize the patient arrest, what would you do in such a situation?
Again, we'll start on ACLS guidelines, and I'll give 50 mg bolus of altiplase.
Okay, you will give the bolus of altiplase, or if you have tenecteplase, give the bolus. And here again, you will continue CPR for about 60 to 90 minutes before you call it off. Is it not? Right? Okay,
Yes.
then. Now, after giving tenecteplase or altiplase, so that is a thrombolytic agent, is it not? So that's a thrombolytic agent. After that, what will be the care that you're going to give this patient?
So no immediate pricks, sir. So we see that for at least 24 hours, no immediate pricks are there, and ABGs and everything, if needed, we'll secure an arterial line, sir. So prior to giving the bolus and all.
Okay. Okay. So how will you follow up these patients after you're giving tenecteplase to prevent further such events? You're going to?
We'll start anticoagulation, sir, immediately.
Okay. What is the choice of anticoagulation?
If I'll start with unfractionated.
Okay, well, why did you choose unfractionated heparin?
No, because if at all, if there is any bleeding, because we have given thrombolytic, and if there is any IC bleed, we can immediately start unfractionated heparin, and it has got short half-life.
Okay. Okay. Suppose I say that the patient is conscious, moving all four limbs. So is it okay to start low molecular weight heparin?
Yes, even low molecular weight heparin can be started. But just for the convenient state that we can stop unfractionated heparin if in the event of any bleeding from anywhere later.
Okay. Okay. Let's say that you have two opinions, two people saying, I want to start low molecular weight heparin, and one another person saying unfractionated heparin. In this particular patient, which do you think you prefer? Any other particular additional reasons why you'll prefer one or the other?
We can monitor.
Thrombocytopenia is a risk, sir. And
with both
patient
with
is-
both the thrombocytopenia is the risk.
we
Maybe
can-
the risk is slightly lesser with low molecular weight, but then with both thrombocytopenia is the risk.
We can monitor
patient is also-
repeatedly.
as
Okay,
a
given
patient
that
is a
the patient
CKD
has got
patient,
okay, given that the patient has got background of CKD, does it influence the choice of an agent?
yes, sir. Heparin is preferred. I mean, unfractionated heparin preferred over low molecular weight heparin in CKD patients.
Especially given that the background of CKD, and you're worried about how to monitor these particular patients, because at least you know, but it becomes very dosing becomes very problematic in patients with CKD, especially when you're going to dialyze them, is it not? So that's something that we will know. Okay, so you are saying that if a patient has got massive pulmonary embolism, you're going to give him a IV thrombolytic agent, intravenous thrombolytic agent appropriately, and followed up with the systemic anticoagulation. That's what you said. But I understand that you've also used a chemical anticoagulation, an IV and a thrombolytic agent, plus a mechanical thrombectomy. Now, can you just tell me the evidence for what we have done and the rationale, and can you just explain how would you approach this in other situations? Is this the norm, or why do we use it? Can you just elaborate a bit more on that?
So mechanical thrombectomy can be used after failed thrombolysis, sir. After failed thrombolysis,
Okay.
the patient is still having the symptoms and evidence of RV dysfunction. Mechanical thrombectomy can be used, sir. Basically, here the
So
thrombus was macerated.
can you tell us when do you call it failed thrombolysis?
The phased thrombolysis.
You said failed thrombolysis, right?
Yes, sir. Failed thrombolysis. Yes.
Can you just elaborate a bit more on what is failed thrombolysis?
So, patient with hemodynamic instability and 2D echo features of RV dysfunction, even after the IV bolus of systemic thrombolysis, the symptoms continue and there is no change in the 2D echo features. So we can call it as a failed thrombolysis, and we can use catheter guided, maceration and thrombectomy.
Okay. I understand that you do have catheter based interventions that are possible, but I'm just asking you, in situations where these are not available, obviously this patient is not shiftable. He's still hemodynamically unstable. So what else could have been done in a situation where it's not available?
Surgical embolectomy.
Surgical, so options are surgical thrombectomy, catheter guided, and IV, systemic thrombolysis. So apart from these,
so the question is, how long after IV thrombolytic or a systemic thrombolysis, how long would you wait before calling it a failed thrombolysis?
So 36 hours normally we wait, sir.
Okay. Okay. So did we wait that long in this situation?
No, sir. Actually, in our case, we did not wait for that long.
Mm-hmm.
Because the
around
process were further worsening, supports were there. So, and RV repeated 2D echo multiple times was showing this same status. So we went ahead with catheter guided thrombectomy.
Perfect. So you've complemented your IV thrombolytic with a mechanical thrombectomy. Of course, when you did the pulmonary angiogram, you did find that the thrombus load was much lesser. No, it's only unilateral, right? It was unilateral and limited to the subsegmental lobes only. So maybe in situations where these patients can't be moved, and in places where you don't have the availability of a cath lab or the expertise for the procedure, after a thrombolysis, continued anticoagulation and an appropriate dose would suffice. Now coming to unfractionated heparin, if you have used it in this particular patient, what is your target? You said you're going to monitor it. What are you going to monitor, and what is the target for monitoring?
APTD, we are going to monitor, sir, and if it is ACT, activated clotting time, we target it as more than 200, sir, more than 180.
Okay, APTT, how much do you want to target?
60 to 70 range, 60 to 80 range.
60 to 80, 60 to 90. Okay, perfect. Okay, then. This particular patient had thrombocytopenia, hit, and you particularly said that hit antibodies were negative. Why did you say this?
I mean, thrombocytopenia was there, sir. I mean, initially his platelet count was 1,40,000. Then it started to dip. And second day,
Okay.
so they have sent hit antibodies early on, sir. I don't know why, but those are negative, sir.
Can you show the trends in your table? There are trends, no, of how the platelets went down.
Yes. So this is the platelet, sir. Initially it was 1.4 lakh, and on the day second 2 itself it was 61,000, and it is continuing to decline and reached the nadir of 36,000 on 29. And then here we have infused 4 RDPs and 1 SDP, sir. So it came to 69,000, and then it stood around 53,000, 80,000, and then it maintained, sir. Patient got better basically. And at this point of time, we were able to wean him off vasopressors. We were extubated him, and the patient was also getting better, sir. And his
so you check the hit antibodies because you thought that there was a possibility that the patient had hit. So I'm just asking you, when do you suspect hit?
Hit usually at 5 to 10 days of treatment, we suspect the immunological hits, non-immunological hit and non-immunological hit. So immunological hit develops usually 4 to 5 days. And then the nadir, and we basically use the hit score to determine, sir, clinically. And if it is like high suspicion, then if we send the hit antibodies, if it is positive, then we treat with we stop the hit heparin, sir. We use the alternatives.
Okay. Can you just explain to me about the hit score?
Hit score consists of 4 variables, sir. Prothrombin time, platelet count, thrombosis, and time for onset of thrombocytopenia, sir. Thrombocytopenia, time to onset of thrombocytopenia, prothrombin time, and thrombosis.
So any evidence of thrombus or other causes of thrombocytopenia we rule out, sir?
The score will vary from 0 to 8. Anything more than 5, I mean anything 6 or more, it is a high probability of hits.
Okay. In this particular patient, suppose the initial platelets are 1.4 lakh. Suppose the next day the platelet, say after 5 days, the platelet was 1.2 lakhs. It's dropped. Will you still suspect it?
Oh, it should be more than 50% drop is more suggestive of hit, sir.
Okay.
50% on the baseline.
So the answer is that you'll start suspecting hit when there's a platelet drop of more than 50% from the baseline, generally after 5 days of initiation. Of course, it can occur earlier if the patient has been previously exposed to heparin or heparinoids before. And once that happens, you start using the score and trying to evaluate whether this particular patient is having hit or not. Fine. Okay. So suppose this particular patient had submassive PE. So we've discussed massive PE. You said massive PE is IV thrombolysis plus systemic anticoagulation for a reasonable period of time. Or if the patient has got failed thrombolysis, you're going to supplement IV thrombolysis plus with a mechanical thrombectomy or a surgical thrombectomy. And if the patient has got risk factors for IV thrombolysis, probably you will do catheter-directed procedures. That's what you said at this point of time. I'm just curious to know, our first question was on submassive PE. Suppose this was a submassive PE, how would we have managed this patient?
Submassive PE, I mean, without the hemodynamic compromise, we would initiate anticoagulation, sir. Only the anticoagulation.
Okay. Okay.
Patient is normally the guidelines say in submassive P we should not go ahead with systemic thrombolysis. Having said that, case where the patient is young with a low bleeding risk, maybe still we can try systemic thrombolysis.
Okay.
What is the trial? Any trial, that
Pithos trials.
what is the other trial that where reduced dose thrombolysis?
Moped trial, half dose source trials.
So what are the conclusions of moped trial?
There was no mortality benefits from half dose.
Whether it's given full dose or half dose, there was no mortality benefit, sir.
So when do you consider basically thrombolysis in submassive PE?
Yeah,
Submassive PE in a way, as you risk stratified hemodynamic stability, and these patients will have generally hemodynamic stability. So submassive PE and with hemodynamic stability, do you consider thrombolysis? If so, when?
No, only if there is RV dysfunction and TROP-I and BNP are raised.
Come on. That is what is submassive PE. No, submassive PE, we define submassive PE as a PE which has no hemodynamic instability but has features of RV stain, as evidenced by an echo or as evidenced by an elevated troponin or elevated NT-proBNP. That's what is submassive. So the question is, the treatment of choice in submassive PE is systemic anticoagulation. What are those situations in, and you rightly said, they have compared about the role of thrombolysis in patients with submassive PE. They've used half dose and they've used full dose, and they found no difference, and there's no mortality difference whether you are thrombolysing or using systemic anticoagulation, whether using half dose or full dose. But you are also right. There have been instances where patients with submassive PE have, in fact, in real life, received systemic thrombolysis. So I'm just asking those situations in which people use systemic thrombolysis in patients with submassive PE.
Young patient with low bleeding risk.
Okay, you said that. Should we use it in a young patient with low bleeding risk? That's more safe, but should we use it? Let's say that you have a patient with submassive PE with an associate with the DVT. Suppose I say a patient with a submassive PE with free floating thrombus in the RA or the another thrombus in, that you can see in the RV. Would it all make you justify the thrombolysis?
Yeah, the thrombus burden is more. So in patient with thrombus burden being more, we can still thrombolyze the patient.
So can we just modify in saying that in a young patient or in a patient with low bleeding risk who's got submassive PE and with the possibility of it becoming a massive PE because there is a risk of an embolization that is just seen on investigations, then there may be a role for systemic thrombolysis. Otherwise, there's no role. In fact, you're only increasing the risk. Is that a reasonable conclusion to say at this point of time? Okay. Yes. Okay then. Okay. Now you did use CRRT in this particular patient. Why did we use CRRT in this particular patient? Or why did we use renal replacement therapy in this particular patient?
So he had metabolic acidosis, one thing, and I mean, like acute or AKI and CKD was there. I mean, creatinine was elevated.
Okay.
So in view of his pH, metabolic acidosis, elevated, AK on CKD, and also hemodynamic instability, we use CRRT.
Okay. Okay. So you use CRRT in this particular patient for these following reasons. What does CRRT do to your coagulation?
CRRT coagulation, like we use like anticoagulation while CRRT, so increased risk of bleeding will be there. But if you use regional citrate coagulation, anticoagulation, then less chances are compared to heparin system.
So in this particular patient, what did you do? CRRT with heparin or CRRT with the regional anticoagulation with citrate?
So we used heparin only, sir.
Sure. Obviously, because there's no data for, as far as I know, for regional anticoagulation of citrate in these situations. Yeah. Okay. You used heparin only in this particular patient. Now, will using the filter and hypothermia, will that affect the coagulation per se? Will it increase the bleeding risk because of you spending more
Hypothermia,
time in the
sir.
CRRT?
Hypothermia
Okay.
itself
So,
can.
what is the temperature of these patients? What is the temperature of these patients that you maintain?
In CRRT, we maintain normal temperatures. 37 degrees centigrade.
So, you have a CRRT warmer.
So we keep separate body warmer.
So, you keep a separate body warmer in this patient. Okay. Okay then. So, this patient has got ketosis also, you said initially. So, how did you manage the ketosis?
No, sir, it was outside report. When we came to our hospital, it was 0.6 or 0.3 of ketones, sir. So ABG, we have taken an endocrinologist opinion and we have normalized his blood sugar, sir.
Sure. Okay. Okay then. Are you still having anything to say? You come.
We can go back to the previous slides and there is course they can tell, sir. Yeah. So what happened on day two?
So day
On
2,
day two.
CRRT was continued. Vessel pressure requirement gradually decreased, and thrombocytopenia was there, after which HIT antibodies were negative. And on day 4, we have infused 4 RDP and 1 STP, sir, for thrombocytopenia. And patient also had a ischemic hepatitis, sir. His SGOT, SGPT levels were raised, sir. So they were in thousands. So on day 3, his PF ratios worsened, sir. For initially, it was improving trend, but on day 3, his PF ratios worsened. So it was around 100, 110 like that PF ratios. Earlier, it was like more than 250. So in view of worsening PF ratios, patient was prone. And also the lactates were elevated. Thrombocytopenia got worsened. Patient had new onset fever, sir. Initial, he didn't have any fever. So after 3 days in ICU, he started developing fever. So we started CRRT with the auxiliaries filter, sir. On day 3 itself, day 2 itself, at the end, we stopped CRRT, sir, as the patient was improving hemodynamically. But in view of worsened new onset fever and worsened PF ratios, we started CRRT with auxiliaries filter, sir. And chest X-ray showed no new infiltrates or no increased secretions or purulent secretions.
So what might be the reason for hypoxia, worsening hypoxia in this patient?
Worsening hypoxia, we were not able to exactly find out what exactly was the reason, sir. So he had new onset fever, so sepsis might have contributed, sir. But the immediate chest X-ray has not shown any clinically significant patches or anything, sir. So, but in view of CRRT and all, the patient was not amenable for taking to CT chest also, sir. CT scan.
Okay. Why was the patient prone? Why was the patient prone?
So the PF ratios were low, and despite having optimal ventilatory settings, in view of worsening PF ratios, we thought of giving a proning, one session of proning, sir.
What was the thought process behind proning? I understand one reason was PF ratios was low. Any other thought process?
I mean, on auscultation, they were crept, sir. So, we thought like it could be some worsening pulmonary edema or something, sir.
Sepsis induced
prone-
मतलब ARDS
Sepsis induced ARDS could be a component, but there were no clear-cut signs. Sir.
You said pulmonary edema. You said pulmonary edema. Do you prone patients for pulmonary edema? No.
non-cardiogenic
Non-cardiogenic pulmonary edema, ARDS, secondary ARDS.
Can you you said there's no patch.
Yes, chest X-ray, there was no clear-cut patch, sir.
Okay. So do you expect?
Because of
what
worsening,
I'm trying to ask you is, we prone patients with severe ARDS, right? Of course. Obviously, PF ratio less than 150. Though when you say severe ARDS, it is less than 100. But because the initial Prosiva trial include all patients with less than 150, that's what we extrapolate and do it. So I'm just asking you, would it have been wrong if this particular patient was not prone and continued in conventional supine ventilation? I'm just asking your thought process.
It would not have been wrong, sir, but as you said, like moderate to severe ARDS, it is less than 150 and they have a clear benefit. So we actually waited for like 4 hours gap, sir. So the PF ratios were worsening it. They were not improving. So in view of that,
was a repeat echo done at this point?
Echo, yes, sir. Echo. At this point of time, there was no echo done, sir. His vasopressor, requirement was normal only, sir. I mean, it was not increasing or there was no signs of cardiac dysfunction or anything.
Okay.
And also, we had tested for NT-proBNP also. At that time, it was 94 something, sir. 94.
Okay. Okay.
So generally, severe hypoxemia can also happen with if the underlying PTE worsening because of the increased shunt. But as you said, there was no worsening of hemodynamic instability. Possibly, there might be lung pathology rather than the worsening of PTE. That's the reason you might have considered for prone.
Yes, sir.
I think it might be a pulmonary edema component.
Okay. Do you think the patient had pulmonary hemorrhage that could have caused? No, because he was on systemic anticoagulation anyway. No, he was on heparin, right?
Yes, sir. That
No
could be a
drop in
possibility,
hemoglobin
but,
or any fluffy infiltrates or anything seen on the chest X-ray. And
No.
no on EP secretions also there was no any indication of any hemorrhage, sir.
Okay. Okay.
ET secretions, no
So how much?
hemorrhage. Yes, sir.
Okay. How much was the FiO2 when you prone the patient in supine?
Supine, it was 40, sir. And when we prone the patient, we made it to 60, sir.
Oh,
Okay.
when he was
So I'm just going back to your question. If you can look at the Prosiva trial and tell me who are the candidates who were identified in the supine position to be prone.
Prosiva trial,
40% FiO2, no? 40% FiO2. I'm not even asking you why you prone or why not. I'm just trying to tell you, could you have, in the absence of a clear-cut evidence that this is ARDS, because you said that you've not seen a patch, you've not seen secretions, and there could be alternate reasons for it. Maybe he had a recurrent of PE. And at that point of time, you didn't do an echo at this point of time. I'm just trying to ask you, would you think you could have done something more in the supine before you actually considered proning?
Actually,
it's just a discussion.
Actually, you could have increased the FiO2 ratios and PEEP further, and and also check for again the LV function, though the BNPs were normal.
Okay. Was the patient paralyzed or sedated at this point of time?
Yes, sir. For proning, we have sedated and paralyzed the patients.
No, before proning.
Before proning, no, sir.
Sedated, sir.
My mildly sedated with the RAS score of 0, sir.
CLAS score of 0. Okay, because what are the risks of proning in a patient who's receiving systemic anticoagulation?
Proning,
I'm sure you have to continue to use systemic anticoagulation in this patient, is it not?
Yes, sir.
Is there a risk? I'm just, if so, what are those risks? Obviously, if the patient needs it, we'll have to do it. No question asked. But of course, we'll have to tell the attendants what are the risks that we anticipate.
Increased cranial pressures is a relative risk in proning, sir. So risk of like anticoagulation in proning, there might be a chance of bleed, sir.
And if patient is sedated and paralyzed,
Obviously.
if there is an IC bleed, the clinically we may not able to pick it up early.
Okay, that's there. But do you see? What do you think about orbital hemorrhages, hemorrhages in the eye in these patients that can happen? So if we can avoid proning, of course, if the patient needs proning, we need to. I'm not even saying this, but since you also have a very iffy diagnosis of whether this particular patient should have been proned or not, I'm just questioning, should we have done something more in the supine ventilation before even considering proning? What are your thoughts on that?
Yes, sir. Those things
Hello,
are
sorry.
considered.
Fine. Okay. Can we just continue?
Patient was proned. I mean, in the glucose lactase were elevated. There was worsening thrombocytopenia, and patient had new onset fever. So, in view of new onset fever, patient CRRT with oxidase filter was initiated, sir. So, initial blood and urine culture sent from ER1 negative, and repeat procalcitonin was 0.83, sir. So, at this point of time, it was like totally pointing away from the septic shock, sir. So, PF ratio started improving after 18 hours of prone ventilation. Sedation paralytics were stopped. Mechanical ventilation continued in supine position only. Acute kidney injury, the renal parameters were getting better. And for thrombocytopenia, given 4 RTPs and 1 STPs. So on day 5 of ICU.
Can we go back? This particular patient's worsened, hypoxemia worsened. At that point, did this patient receive any transfusion?
Hypoxemia worsened. I mean, for platelet counts, he has received.
You prone the patient. No, he had a worsening hypoxemia.
Yes,
and,
sir.
At that time, did he receive any transfusion?
No, sir, not at that point of time. After we have, on day 4, after the morning platelet count showed a drop in trend. So that back then it was 36,000. Then we transfused, sir.
Sure. Okay.
So on day 5 of ICU, his hemodynamics improved, renal parameters improved, liver function test improved, and CRRT was discontinued, sir. So day 6, patient was extubated and was maintaining saturation on 2 nasal bronchs with 2 liters per minute of oxygen. Thrombocytopenia improved, hemodynamically completely stable. He was off vasopressus, and repeat 2D echo showed good biventricular function, sir, with no RV dysfunction. So these were his labs. So at 29, that is day 5 of ICU, he has 36,000. This was the nadir of platelet counts, at which point he has received 4 RDPs and 1 STP. And after that, there was improving trend only, sir. And 31st, it was slightly decreased, but it was improving trend only, sir. So this was when his counts were slightly elevated, sir, from 8,600 to 10,000. This was when he had this worsening PF ratios and fever spikes, sir. So this is the, renal parameters which have gradually improved over day. And at discharge, it was 0.95 of creatinine, sir.
Oh my God,
So
you
we-
normalized CKD, the patient's creatinine. Is
He
CKD.
was a known CKD, and it was like taken 2 years back, so that 1.8 of baseline creatinine. And this patient had received 4 days of CRRT, sir. Maybe that could be the possibility that his creatinine is very low.
Mm.
And liver function tests showed ischemic hepatitis, and these are also were gradually liver function tests also recovered, sir, at the time of discharge. This was his ABG, sir, and at severe PF ratios, decrease in PF ratios, it was 40, sir. We were not sure whether the high FiO2s and this was implemented back then. But I think he might have used, sir. We might be missing some data. So after proning, it was maintained at 60 and with a pH of 7.41 and PO2 of 72, sir. So the PF ratios were more or less like 110, 120, like that only. And then they gradually improved 60 and with 143, giving us more than 200, and with 50 or 145, close to 300.
Okay.
I think just to discuss basically, suppose any patient is being young, suppose maybe below 40 years and presenting with severe pulmonary thromboembolism, the moment he came to you and then as sir initially telling that this patient can have initial sinus tachycardia, then land up in bradycardia, which is ominous sign, and then land up in pericardial arrest situation. Suppose a scenario like where this patient being arrested. So at that point of time, you started CPR and there was ROSC being achieved and still continues to be very severely hypotensive. So any other options other than like, anyway, you will be thrombolizing and all things you will be doing. But other than that, any other options, especially in young patients, you will be considering?
VA ECMO we can start, sir, along with other modalities like thrombolysis or thrombectomy. VA ECMO is the option we can answer.
Yeah. So the role of VA ECMO, basically in these patients, probably you start VA ECMO until definitive therapy has been started. Probably start VA ECMO and stabilize the patient, then go for a catheter-directed thrombolysis and all. So there is a role of VA ECMO. We can maybe, I think nowadays more and more centers are doing ECMO. Probably that's one thing that we can consider. Suppose if there are any contraindications to thrombolytic therapy in this type of patient, like subset of patients, so how do you proceed?
If it is a relative contraindication, I can still go ahead with catheter-guided minimal dose thrombolysis. If it is absolute, then thrombectomy or can go ahead, sir. So catheter-guided thrombectomy.
Systemic
Without thrombolysis.
Okay. Any patient coming with recurrent DVT PTEs symptoms and presenting landing up in PTE recurrently, probably in these patients, if there is a contraindication for anticoagulation, how do you proceed?
IVC filter is an option, sir.
Okay.
Current PTE with established DVT, IVC filter we can use, sir. If the patient is having contraindications for thrombolysis. So basically according to IPEC study, IVC filter can be used if there is failed, recurrent thrombolysis and patient is having absolute contraindications for thrombolysis. In these patients, we can use IVC filters. And also,
what are the types of IVC filter?
Types, I'm not sure. I don't know.
Basically, non-retrievable and retrievable filters. The patient having contraindication to anticoagulation with recurrent DVT, probably that is the case scenario where you consider. But if the contraindication for the anticoagulation can be mitigated in the future time, probably retrievable IVC filters can be put. And once the contraindication has gone, then probably retrieve the IVC filter and then start anticoagulation. So you have to individualize accordingly. So in this case, what do you think is the reason for his pulmonary thromboembolism?
Left lower limb skin and soft tissue infection, but we suspected DVT, sir. But compression ultrasound did not show any DVT. but compression ultrasound is not 100%, does not have a 100% negative predictive value as well. And moreover, like he has a diabetes and CKD, that might have restricted his skin and soft tissue infection, sir. So diabetes, hypertensive, elderly, all this predisposed to thrombotic state. So
How do you proceed about future anticoagulation?
future anticoagulation, first I will evaluate, sir. I mean, the risk factors, whether it is moderate, I mean, like the reason for pulmonary embolism, what are the, I mean, like the causes of pulmonary embolism. If it is like very high, greater than 10-point risk, like surgery, immediate trauma, more than bilateral lower limb fractures, such things which are reversible are present, then we would go for thrombolysis, I mean, anticoagulation for at least 3 months, sir, but not more than like 1 year or so. But 3 months of anticoagulation we'll use. But in intermediate and high risk patients, we can use 12 to 24 months of anticoagulation minimum, sir. Like cancer patients is high risk. Intermediate, like pregnant patients, APLA patients, OHA patients having this PTE, these all come under the intermediate risk, sir. So
It's basically
from,
divided in between provoked and unprovoked DVT PT.
yes, sir, provoked, unprovoked. For unprovoked DVT, we will evaluate for the cause, and if no cause is found, then lifelong anticoagulation for unprovoked DVT, and for provoked DVT, at least 3 months of anticoagulation.
So, what do you think in your case? You think it is provoked DVT? You don't find in the limb, but probably it might be already migrated thrombus.
Yes.
You think it is a provoked DVT or unprovoked?
I feel that it is a provoked DVT.
Okay. Dedeepiya sir, any other things from you?
Nothing. I think.
Sir, we have covered almost, I think. There are some questions, sir, from attendees.
It's past time. So.
Yeah, sir. 1 or 2 questions are there. In a patient with massive PE followed by cardiac arrest after RBC, can we go for thrombolysis?
After ROSC, should we go for thrombolysis? Yes, you should. If you think differential is PE, you should thrombolyze these particular patients and continue CPR for an extended period of time, as we discussed before we say it is futile. So, and as already discussed, there's a role of an ECMO CPR in these particular patients in the right settings. Especially if they have a chance of reasonable neurological recovery and depending. I think that's the way forward.
Yes, sir. One question, like bicarbonate therapy with PS 6.9 in this patient. Role of bicarbonate therapy.
We did discuss that, no? Because we were just saying that if you're going to intubate these patients with 6.9 and take over their respiration, momentarily the pH could drop further, because until that point of time they were compensating because of their hyperventilation. So momentarily we are dropping their minute ventilation. They are because of an acute sudden rise in PCO2 that you could have a worsening. So there may be a role of a judicious use of bicarbonate in these patients, and we did discuss that you could see some peri arrests in these situations. So you're justified in using bicarbonate in this particular patient as at the peri-tubing instance to prevent adverse cardiac events. And obviously, these particular patients, because you could anticipate a further worsening of hypotension, you'll have to start them on inotropic support, which was done in this particular patient, because I think he was already hypertensive. But if this patient was not hypertensive and you are intubating these patients, anticipate that they could have a cardiac arrest, and it will be judicious for you to prepare and keep noradrenaline or other vasopressors ready and not be actually searching for it once he becomes hypertensive. So that's something that I think we should keep it. And this question actually brings that particular facet of being prepared into.
Yes, sir. Yes, sir. Right. That's rightly said. Yes, sir. I think we come to the end of the session. Thank you, Dedeepiya Devaprasad, sir. Basically, so we had covered almost all aspects in one case from all the angles. So thank you very much, sir, for sharing your clinical insights and experience. I think it's very beneficial to all the students. And thank you, Dr. Mallikarjun and Dr. Syed Ahrar, for bringing out the case
Thank you.
which went through.
Thank you so
Very
much.
nice and good recovery for the patient. So, any final comments from your sir, Dedeepiya sir?
A very, very nice case, nicely managed. Of course, we could always discuss about certain points which could have been done different ways, but I think that's individual left to the clinician. But the point that we wanted to discuss in this forum was when to diagnose PE, how to differentiate between massive and submassive PE, what is the treatment options for massive and submassive PE, when do you call it submassive PE, when do you thrombolyze patients in submassive PE? What are the complications that you anticipate? What is failed thrombolysis? And I think we probably, and how do you manage post thrombolysis? We did discuss about anticoagulation and the duration of anticoagulation. I think most aspects were covered, and of course, some other aspects like HIT and all that did come up in the discussion and was covered. So thanks for calling me, and it was a wonderful case presentation, and congratulate all involved in making this presentation, of course, and in treating the case also. Thank you. Thank you.
Thank you, sir. Thank you,
Thank
Yashoda
you, sir.
Hospitals and our digital team for this regular webinars. Yeah, Mallikarjun.
Thank you, Kaladhar sir, for this opportunity. It was a wonderful opportunity. Looking forward
Yes.
to more such opportunities.
Thank you.
Thank you, sir.
Thank you very much. Good night.
Thank you.
Thank you, sir.
Good night.